Good afternoon. My name is Wilson Zito. I'm a cardiovascular surgeon from the University of Pennsylvania in Philadelphia. And we are here today at the Society of Thoracic Surgery annual meeting, Aortic Dissection Roundtable discussion. And today we have a distinguished panel of aortic surgeons with expertise in this field. And today, hopefully, we'll have a collegial discussion about the current therapy and controversies in aortic dissection. I'm going to start off by introducing Eric Roselli.
Hi, I'm Eric Roselli. I'm a cardiac surgeon at the Cleveland Clinic and looking forward to a great discussion today.
I'm Mike Fishbein, a cardiac surgeon at Stanford University.
I'm Edward Chen. I'm a cardiac surgeon at Emory University in Atlanta, Georgia.
Well, aortic dissection is a lethal disease, and it could potentially be very difficult to manage, even in the hands of expert aortic surgeons. There have been many topics and controversies discussed at this meeting on our aortic session. So we'll start up by having some open-ended questions that I want to discuss with the rest of the panel. First topic we should perhaps discuss is, very simply put, when a patient arrives in the operating room in distress, how do you proceed and how do you do your conduct of operations? First obvious question is, how do you get this patient on coronary bypass and get the operation done? And there have been discussion about central cannulation, femoral cannulation, axillary cannulation, and I would love to get comments from everybody here in the group in terms of what their preferences and their rationale. I'll start with Eric. What do you do at the Cleveland Clinic, and what are your thoughts regarding what's the best approach?
Well, I think, as you've alluded to, the most important thing is to get the patient well perfused. Mm-hmm. And there are multiple ways to do this. At our institution, we found for quite a long time that using the axillary artery has improved outcomes in patients in general when we need to use circulatory arrest to optimize flow in the true lumen in patients and to assist with brain perfusion. But I'll tell you that lately, and it started because I've had a couple patients where we haven't had time to get access to the axillary artery, where we've used a central cannulation technique with basically a modified Seldinger technique with an ECMO cannula, where we access the true lumen centrally right off the ascending aorta, and been really happy with that approach. Very rarely will we use the femoral artery as our cannulation site in our institution.
And it's similar at Stanford. Always our preference is axillary cannulation, but certainly if it's someone who's unstable, sometimes we'll open the chest and just simply decompressing will allow you to have some time and allow you to go back to doing the axillary cannulation. But our preference is always antegrade flow, so we try to avoid femoral cannulation unless you really need to for an emergency. And also one other thing to keep in mind is that you can always go directly through the left ventricle, put a wire through, and then go across the aortic valve, and that could be an emergency access for your cannulation strategy.
You're referring to a transapial kind of approach.
Exactly.
Mm-hmm.
Yeah.
Ed, what are your thoughts?
Well, Wilson, we also believe in antegrade flow through the dissected aorta. I think, the dissection, as you guys know, is a very dynamic process. The flap can cause severe malperfusion, and we're concerned about retrograde flow through a femoral artery. We've not used the femoral cannulation in 8 years. We've typically used axillary cannulation. We do have situations similar to Eric's where the patient's unstable or they may arrest on induction, and there's no time you just don't have that 20 minutes to put that catheter on, and so we'll go straight to the central cannulation as well, directly into the ascending aorta, either under epi-aortic guidance or direct visualization. But we try not to do that because we always remain concerned that manipulating the dissected aorta could lead to further malperfusion, embolic events, stroke, things like that, or some sort of rupture. So even if the axillary artery is dissected, I should point this out, that we get this question a lot from the residents. What do you do if the axillary is dissected? We'll still use it because we'll put the cannula in the true lumen and try to maintain true lumen flow that way.
That's a great point. I've had patients where the dissection extends way out on the axillary artery, and what I've done, if there's time to do so, is repair that artery directly while we're there and put an interposition graft on the axillary artery and then sewn another graft off the side of it. And then we know we're getting true lumen flow. The question I'll throw out to you guys, though, is because it is always a concern. When we think we're in the true lumen or we know we're perfusing antegrade, we're certainly more certain about perfusing the true lumen. Do you guys use any particular monitoring techniques to confirm that? For example, measuring pressure in the left arm or using cerebral oximetry?
Well, Eric, that's a great question. So at Penn, we have also now gravitated more towards a central cannulation technique with the echo guidance, a Seldinger technique, where we have confirmation that our cannula is truly in the true lumen. And the fallback will be axillary. We've done more and more of the central cannulation technique. Similar to most of you, we have not done a whole lot of femoral cannulation anymore, other than the fact that it may be a redo or the patient is just in extremis and I cannot get in there quickly centrally. Great question about monitoring. I like bilateral radial A lines, so I know what the left and right side are doing. We also routinely, after going on pump, after cross clamp, we routinely will do bilateral carotid ultrasounds to make sure that there's no malperfusion, and that is part of a protocol for anesthesia when they are helping us with the case.
So you have the anesthesiologist just put the ultrasound probe over the carotid?
Correct. That is our standard protocol to make sure there's no cerebral malperfusion. Absolutely.
So we've simply been looking at oximetry and seeing, for example, do you cool both sides equally and at the same rate? And then the other thing is we just look with transesophageal echo and make sure that there's flow in the true and the false lumen.
Yeah, and I think we do those similar monitoring mechanisms in echo, BIS, bilateral oximetry. I would point out, Eric, you bring up a very good point that if you have a radial A line on the right radial and you're using right axillary, that pressure is falsely elevated.
True.
So it's important, I think, for people to know that you must have either contralateral radial A line or femoral if you're using axillary cannulation, because there have been incidences of malperfusion when that was not done.
Great point.
That's extremely important to do.
And that's another reason why we have gravitated more towards a central cannulation technique in the event that you only have one A line in. That's more accurate.
Wilson, when you do that, what cannula do you use for the central
I just use a standard femoral arterial cannula that you can go through a Seldinger technique.
Yeah, like an ECMO cannula.
Exactly.
Right?
So
Yeah.
under echo
Same.
guidance, in accordance with what you see on a CT scan, confirming where you think the true lumen is, we puncture oftentimes into the false lumen, through the membrane, into the true lumen, because usually anatomy, it's on the lesser curve, of the ascending arch. Confirm that with TEE to make sure the wire's in the right lumen before we commit to cardiopulmonary bypass.
I think it's important to know that in a type A, in the ascending aorta, the false lumen is often on the greater curve.
Exactly.
So you want to stick that cannula in, if you have to, on the lesser curve, particularly the underside of the arch. Open the AP window and put it there, because typically you'll more likely not be in the true lumen.
Correct, and I generally refer to my residents to them as it's sort of a double pop feeling. The needle goes through the first layer, adventitia into the false lumen, and then you got to cross the membrane into the true lumen. So it's two pops.
We could talk about cannulation
All
for
day.
20
But let's
minutes.
move to the
I
next
think.
topic.
But let me just ask one
Yes.
more question. Have you guys had any situations where you're in the operating room and you think the perfusion's going great and then you've had a change?
Absolutely.
I bring it up because I have, and I think it's important for the audience, because these are tough cases, to just highlight an important thing is that make sure there's good communication lines with your perfusion team, because if they notice resistant changes or something like that, you have to have in the back of your mind, I think, an alternative strategy to switch things out.
Eric, for our conferences, one of the things I always ask our residents is, so let's just, no matter what, let's say you're doing femoral or axillary, and you're cooling, and your perfusionist is telling you got a high line pressure, you can't flow more than a liter, and your pressure's low. What do? And so one trick what we've done is we just we turn off the pump, the patient's heparinized, so you turn off the pump, transect the aorta down low by the sinotubular junction, and then you stick the cannula directly into the ascending aorta, and then you clamp, and then so you know it's in the right lumen. You start, air, and then you just clamp and then go back on centrally if you have to do that. And that's happened a few times, not just because of malperfusion, but also because someone may rupture and you've got down low by the root, so you've got to, and if you rupture, you've got to sort of seal that hole, otherwise you won't maintain good perfusion pressure.
Right. That's great. Yeah, I think, if you don't think about that beforehand,
That's not something you're going to make up on the fly.
No.
It's got to be in your armamentarium before you get started.
The clock slows down quite a bit.
Okay, so let's move to the next topic.
Yeah.
I know go ahead, Mike.
Yes, I think that brings us into our next topic, which would be what is your individual strategy for cooling? Do you use profound hypothermic circulatory arrest? What is your cooling strategy? Or do you go to 20, 22, or we've heard also at the meeting there's some interesting abstracts where people have cooled just to 28. So why don't we start off?
And what the adjunct cerebral perfusion strategy with the temperature as well.
Well, Mike, as you know, there's a lot of different techniques that have been described in the literature, and there's really, this topic remains debated. There's no ideal way. Over the years at Emory, we have gone more toward moderate hypothermia. We typically will circ arrest, 25, 28 degrees, but average, if we look back at our patient population, it's about 27 degrees that the patients have, where we stopped cooling and circ arrested. We have just found that degree of hypothermia is enough to protect the lower half of the body, and the cerebral protection we use is antegrade cerebral protection through the axillary artery, and we'll monitor both. We use the cerebral oximetry to monitor SATs on both sides of the head. Typically, we may stick a cannula up the left side. We try not to do that because, again, we just don't want to manipulate the arch. And if we have to, occasionally we may occlude the left carotid artery to pressurize the entire system. And we're not too worried about the circle of Willis because we know there's plenty of collaterals going through the extracranial circulation to perfuse both sides of the head.
So we do a similar perfusion strategy, although I would say in general we cool to about 22 degrees. If it's somebody who's morbidly obese, we don't want to cool that low. We'll cool to about 24. And our strategy for perfusion is axillary cannulation. We do tend to clamp the left carotid and manage or monitor with cerebral SATs. And if we do see a decrease in the left side, then we'll put an extra cannula up, although we do tend to get nervous if the carotid is dissected to put anything up the carotid.
Our strategy's been a little different, I think, and I'll have to speak for myself because it is really surgeon dependent. But I would say we all fully believe in the benefits of selective antegrade brain perfusion for complex arch reconstructions. That's been a great advance. But for the acute type A dissections where we don't know exactly what their intracranial circulation is like, we don't know what's going on with the dissection flap between our cannulation site and the intracranial vessels. That's been a concern, and we've had good success with deep hypothermic circulatory arrest. That's what we've continued to use predominantly as our brain perfusion strategy in Cleveland. And in addition to that, we use retrobrain flow. I don't want to say perfusion, but retrobrain flow to keep the head pressurized and keep air emboli out of the head. And typically we'll cool to at least about 20 degrees Celsius. The typical cooling time is about 20 minutes to get to that. What we look for, certainly in my room and many of my other colleagues, is that we get the BIS down to 0 before we arrest. So we show EEG silence, and we feel pretty good that we've got the brain protected. And going a little colder, I don't think has increased our risk of bleeding. That's why I like the idea of moderate hypothermia maybe gets the operation going faster, but with our approach to cooling, we've been able to get the patients cold in 20 minutes and haven't seen a whole lot of different bleeding. So that's still our strategy.
Well, at Penn, similar to your institution, Eric, there's a wide variety of techniques, surgeon dependent, obviously. Traditionally, our program has been a cold program, cold, EEG silence, if the EEG in neuromonitoring is available in the middle of the night. We don't always have that 24 hours. a day, but EEG silence and retrograde perfusion. Over the last few years, I've taken Ed's lead and followed him, and I've gravitated more towards a warmer strategy with ACP. And this is in coupling with the direct cannulation technique I talked about that I'm now doing more and more in frequency. And what's interesting is when those cases are monitored, and we monitor not only with cerebral oximetry, but also with EEG, surprisingly enough, it's quite amazing that oximetry is stable bilaterally, and even the EEG, when your brain's perfused, really does not show any diffuse slowing. So from that standpoint, I think a warmer approach with ACP is certainly an acceptable strategy and has good brain protection as long as you know it's monitored and that you're doing the right thing.
So do you cannulate the supraortic vessels directly in those patients?
Correct. What
then
happens?
with the central cannulation?
Absolutely. So I turn the pump off, and for about 5-10 seconds, I will directly cannulate from within the inside when everything's decompressed and depressurized, identifying the trulin, put up cannulas within the ostium of the left common carotid and the innominate, and then gently put a Rommel around it so that it's airtight, and so that there's no bleeding around it.
And does it influence, let's say if the carotid was dissected, would that influence whether you cannulated it or not?
It has. I mean, I obviously would look at it carefully. Not so much that there's a flap there. I think if there's a true dissection tear, I'd be a little more worried about it. But if it's just an extension of the flap in the ascending aorta and you just have a flap, I'm a little more comfortable about doing that.
And what about bilateral cannulation? Do you believe in doing bilateral, both the left carotid and innominate, or how will you decide what to do?
I'm a little bit more, I have a lower threshold to do bilateral cannulation, just so that I want to maximize cerebral protection in someone in an acute setting like this.
One thing I was going to say is that, although the body is at a higher temperature, we're still perfusing the brain at a pretty cold temperature just to protect the cerebral metabolism.
What temperature is your perfusate?
It's about 16 to 18.
That's
Although
about
we're getting impatient with that too, probably, and we're warming that up a little bit. But I think it's important to know that, at least for us, we recognize that at least our technique is not necessarily better, but in our hands, a safe alternative to some of the traditional methods like Eric has done over the years. And so I think those are in our hands some of the things that we found that have worked out well.
Okay. Before we move on to the last topic, one question I often get asked is, what's the perfusion rate, and how do you decide what's the flow rate and the blood pressure, et cetera, when you do ACP? What do you guys do at Emory?
Well, we start, Wilson, at 10 cc's per kilo per minute. And I think as long as we maintain a blood pressure around 50 to 60, that's at that temperature, the cold temperature, we found that to be adequate. And as you had alluded to, we also find that all our EEG, BIS monitoring, cerebral oximetry, those numbers tend not to fall. I think for us too, as Eric had pointed out, you don't know what the anatomy is like between the origin of the innominate and where the clamp and the axillary cannula. So we do unclamp it a little just to make sure there's blood coming out of the true lumen, to make sure that we actually have adequate perfusion. If not, we'll make adjustments intraoperatively.
So the last topic that's been talked about quite a bit here, and I know we only have a few minutes left, is the discussion about the placement of a stent graft or a so-called frozen elephant trunk. And I'm going to start with Eric. You've had a lot of experience with this particular technique, and you've described it. Tell us about your thoughts. What are your rationale, and do you think it really makes a difference in terms of aortic remodeling down the road?
Yes. I fully believe in this technique, and I think this is where we're going to make a difference in our outcomes in patients with acute aortic dissection, not just long-term with the remodeling, but short-term. And that's something that's been something I found serendipitously. The retrospective analysis of the patients I've treated, and I've treated over 26 now, over 25. Almost half of them had presented to the operating room with malperfusion, and none of them have had important end organ injury or loss related to it. So we've optimized true lumen flow to deliver this stent graft. Although I'll tell you, the reason I started doing this procedure was to promote remodeling. Now, I've seen mixed sort of data. We saw some data yesterday from Dr. Coselli's group in Texas, and they only had 50% of their patients with, or around 50% of the patients with false lumen thrombosis in the treated segment. I think we need to make the procedure a little more standardized. I don't want to criticize the results because they were excellent, and they had a lot of patients with malperfusion who did great.
Correct.
But on a couple of the images, they showed the stent graft looked like it was sitting a little distal in the descending aorta. And so something I've done in these folks is when I put the stent graft in, I bring it up high and I park it in the aortic arch so that we get the aortic arch to seal and heal. Because I found on a lot of the patients who come back for reoperations after surviving an acute type A dissection, the false lumen's reperfused by a little tear in the aorta, maybe at a needle puncture or something like that. And I think it's important, if we're going to do this approach, that we really have a more standardized way to do it. We probably need a better device to do it with.
That was my next point. And what are your thoughts about devices that are currently not available in the U.S.? And because for U.S. physicians, all we have are not disease-specific grafts. What is your technique? What do you do? Is your graft incorporating the distal anastomosis?
Yes.
Just a few words on that?
Yes, I use the commercially available descending thoracic stent graft. I modify it so that there's room for the head vessels to go in, and then I put a few tacking sutures inside the aortic arch to secure it in place, but then also include about half of the device in my suture line. So the way I do it, I still have a hemi-arch kind of repair, so it's a single anastomosis distally with a couple extra stitches. And I know many folks have done more extended arch repairs. I think the reason the extended repair hasn't been widely adopted is because people fear doing an extended repair in a patient. I think we can do it with a better device where we don't have to reimplant all the head vessels and do a really extensive repair, but still get the same result with the device. We need a better device.
Mark,
Eric,
what do you think?
Let me just ask Eric one more question. What do you do on your post-op CT scan if you do see an endo leak? Will you go back and try to repair that, or do you take the attitude that as long as there's no malperfusion, it was a success?
The latter. The latter.
Okay.
I mean, the indications in the chronic situation are still the same. Although on a couple patients where I've seen it and I've been convinced it's because retrograde filling from the left subclavian, I have gone back and embolized the left subclavian artery and then seen the false lumen thrombose. But 88% of the patients had the false lumen thrombose in the treated segment. The ones who failed were patients where I didn't secure it inside the arch very well, and there's a little wrinkle or something like that.
Yeah.
Okay. Finishing up, Ed, I guess you'll have the last comment. What are your thoughts about this frozen elephant trunk technique?
Well, so I think it's potentially a good technique, but as Erica has alluded to, some of the results have been mixed, and I think for us, we sort of taken the tried and traditional approach, with the aggressive hemi-arch that your group has advocated at Penn, to resect as much of the arch as possible, the lesser curve to the level of the left subclavian artery, and then really use that strip of felt as a neomedial layer. And we've just not seen, now certainly we see still false lumen perfusion, but we have prevented, we've not seen a lot of need for intervention. And so it's good to have remodeling, there's no doubt about that, but ultimately we're trying to save a patient from another operation, and we've not been necessarily convinced yet, based on the world experience, that we need to do it every time. I would agree that in cases of either radiographic or clinical malperfusion, it's a great option over some of the traditional methods that have been described.
Okay.
I think the other important thing is not only remodeling, but I think it'll be very interesting to see long-term at 5 years, is there a change in mortality as well.
Right.
And I think it'll be a great thing to maybe do a clinical trial in that randomized trial.
Yeah, let's all work together, huh?
Yeah, absolutely. Well, thank you for being with us today. I hope you find this to be instructional. And on behalf of the panel here, thank you very much for spending your time with us today.